morning, good evening, or good afternoon, depending on where you're joining us from. And thank you very much for joining us today for this exciting discussion on virtual violence prevention programming. I am Rita Nyiratunga, and I'll be co-moderating this webinar with my colleague Ruti. She'll get time to introduce herself. For those of you who are joining and who may not be very familiar with the Prevention Collaborative, I'll just give a quick introduction of who we are. We are a global network of practitioners, activists, and researchers working to better equip ourselves and others with the needed vision and skills. Thank you, Modo. I was saying we are a global network of practitioners, activists, and researchers working to better equip ourselves and others with the needed vision and skills to end violence against women and their children. We work to strengthen the capacity of key actors to design, deliver, and advocate for cutting-edge prevention programs informed by research-based evidence, practice-based learning, and feminist principles. As we all know, we are more than 18 months into the COVID-19 pandemic, and we've got continued challenges, closures, and restrictions around the world. So we will agree that the primary ways we use to do violence prevention work have had changes, as many of our programs relied on the person or group or face-to-face or community work, which actually became more difficult and sometimes impossible in some contexts. At the same time, the pandemic has increased the stress in many homes and families. So many of us, including the Prevention Collaborative, have had to adapt and learn. Our goal for this webinar is to share lessons learned from mainly 2 virtual programs, and we will be hearing from, can you go back a bit? We'll be hearing from myPlan, which was originally developed before the pandemic as an application. And we also hear from the Parenting for Lifelong Health, which pivoted during the pandemic to test new modalities. Okay, before maybe we move, I wanted to share briefly what we at the Collaborative have adapted to do in a more virtual environment. Can you go to the next slide so people can see? We continued our webinar series, as well as started a more informal practitioner-oriented visual coffee series, virtual coffees. And that allows us to connect and learn from researchers and practitioners from around the world. Many of you, I believe, have attended some of those. So with the COVID-19 pandemic, we shifted our signature learning partnership, I would say, accompaniment programs from in-person workshops to online sessions. As our learning partners testify, this has not only helped them and all of us keep the momentum, but has also been an eye-opener on how much can be done remotely and thus minimize the programming costs. So finally, another thing we did, we developed and launched our learning lab, where we offer a growing set of practitioner-focused online prevention courses. Some of you may have attended or heard about those, which we hope will be useful to a wider range of stakeholders than we might have been able to reach in person. So we really hope that what you'll hear today from our colleagues, our speakers today, might also spark for you some creative ideas in this challenging time. I will very briefly introduce our speakers. So to go through this topic today, we are with our great speakers. We have Dr. Nancy Glass. She is a professor at the Johns Hopkins School of Nursing with joint appointments in Johns Hopkins Bloomberg School of Public Health and School of Medicine, and an associate director at the Johns Hopkins Center for Global Health. Dr. Nancy conducts multidisciplinary projects in partnership with local experts and communities across diverse global settings, including conflict and post-conflict countries. So I wanted to acknowledge the presence of Dr. Nancy's colleagues in the audience, Michelle, who maybe talk to us, and folks from the Ujamaa Africa. Thank you all for being with us today. We also have Dr. Jami Lachman, who has over 20 years experience developing, implementing, and evaluating social intervention for children and families. He is a senior research officer at the Department of Social Policy and Intervention at the University of Oxford. Dr. Jami is also a co-founder of Parenting for Lifelong Health and the co-principal investigator of the Global Parenting Initiative. Thank you, Dr. Jami, for being with us. He will be co-presenting with a colleague of his, Schafer, who is a doctoral student in a social intervention and policy evaluation at the University of Oxford. In the research that she does, she investigates the intersection between violence against children and intimate partner violence. And we're happy to have her co-presenting with Dr. Jami today. I will acknowledge the presence in the audience of other colleagues, including Lucy Claver, who will be joining us shortly. So thank you so much all for being with us today. If you can scroll some 2 slides down so we can look into a little bit of the housekeeping, 1 slide. Great. So our webinar is being recorded. We wanted to let people know that we are recording and we'll be sharing even on our website. And if for any reason you don't want to be heard or seen, please mention to us and we'll see how to handle that. We'll be having a question and answer section sometimes, and we will be happy if, as you share your question or your comment, make sure that you activate the button to yes to all panelists and attendees, not just on panelists, so we can share this virtual setting at a time. Great. So if you want to stay connected with us during this webinar, the next slide shows the Twitter handles. Feel free to tweet to us and to our great speakers today. All right. So without any further ado, I'll hand over to our speakers, starting with Nancy. Nancy, are you okay to take us through what you, okay, great. Thank you.
Hi, thank you, Rita. Thank you to the Prevention Collaborative for inviting me and hosting this webinar. I'm very excited to have a chance to have a conversation with colleagues from around the world about integrating technology into programming for survivors and families of specifically, in myPlan's case, intimate partner violence. So what I want to do just really briefly is to say what myPlan is, and then a brief word on what myPlan is not. So this, we have focused, myPlan has been free and accessible through the Android platforms and Apple, as well as a web app since the end of 2017. It is specifically accessible in the US, but you can access it through a webinar, through the web app outside the US. We have focused on really the research is backed by research, and we have focused on collaboration with actually thousands of survivors and advocates around the world to develop and test and adapt myPlan. And I have colleagues here from Ujamaa Africa and School of Public Health who've done this work in Kenya. And we have focused on personalizing it. What we mean is we tailor the resources to the priorities and situation of the user. And we have also adapted it for all genders, as well as there is for male survivors, which is unfortunately not the research that exists for women in abusive relationships is much more deep and rich. The algorithms that support the males' safety planning are not as well developed, but we certainly are working on that. And we do focus on security and privacy. Next slide. So as for everyone on this webinar, safety is paramount. It's the first thing we think of, and the first critique that I hear from colleagues about using technology in programming. I think we need to think seriously about that, because I don't think technology is going away. And I think women have their own agency to decide what's safe for themselves in using a phone or an app. And we also acknowledge that it's not a resource for everyone, and that women can make those decisions when know that it's not safe for them to use the phone, that their partner is monitoring it. But we have worked with women who tell us that they use their friend's phone, or they use a phone in their workplace, or computer in their community center, in their health clinic. So women do find different ways to access the resource. It is PIN code. We have a dummy PIN code. If it's discovered and the partner insists that they put in the password, we tell them to put in the dummy PIN code, and it comes up with, for example, in Kenya, recipes for meals for the family. We've worked with the tech industry around safety and how do you download and information before people decide to download, and then when they're in the app, we really focus on tech safety and understanding the risk of tech facilitated abuse. Next slide. So I just want to give sort of the landscape of myPlan. So when you download and you put in your password, you do the onboarding, the first screen provides you to what we call the basic safety plan. This is where you get information about that we typically talk about in emergency safety plans that are very common in our programs around packing a bag, hiding money, and with some basic resources. And so these are static to all users, meaning they haven't been personalized. Next slide. So what we do next is we say to the user, if you would like to personalize your safety plan and strategies, complete the following activities through our assess component. And there's 4 components to assess, and some of that is my information. Do you have children in the home? How old are those children? Because we want to provide child safety plans based on the age range developmentally, for example. My relationship health, my safety, and my priorities. And we'll briefly go through each of those components. Next slide. So when we talk about assessing, we talk about red flags for an unhealthy or abusive relationships. I know we've all talked with survivors where they're trying to decide what actually is happening in their relationship. Is this abuse? Is this what's considered normal conflict in a relationship? They may have not seen healthy relationships in their own homes when they grew up. So we help women think through, or the user think through, for example, does your partner or ex make you feel guilty for doing things you like to do? So controlling behaviors. And so we provide information immediately back based on their input around how they've described their relationship. This isn't our assessment, it's based on how they define the things that are happening in their relationships that raise red flags for an unhealthy relationship. Next slide. And then we use what is well known in working with survivors around, we use a danger assessment. My colleague at Johns Hopkins, Jackie Campbell, developed this. It's been adapted in many countries and many languages, and actually has been adapted with women who are in same-sex relationships. It's been adapted for immigrant women, refugee women. And so we have been doing continual work on this to improve the risk identification of risk for severe or even lethal violence. And these are common questions and things that we hear women tell us about is, has your partner abused you during pregnancy? Has your partner threatened to kill you? Is there alcohol abuse? And the responses are then provided back to the user through an image. And it really provides information about the level of danger in the relationship. And we've developed these messages and the way we provide this feedback based on how women told us to do this. And I know that that advocates say, oh, we can't give this information to women. It will freak them out. It's too sensitive. But what women tell us is about 50% of women who do this with us, who we studied, they say, yeah, I knew he was that dangerous. People didn't believe me, but I knew it. And then other women say, you know, I knew he was this dangerous. He was the one, he was gaslighting me, making me feel crazy. And so it's not, the other women say, this is really helpful. It scares me, but I need this information so I can make safety planning for myself and my children. Next slide. Then we ask women to we know that women are making decisions every day about their safety. Women have agency, and they're doing things that we may not see, but that they're doing that minimize or reduces their exposure to violence and protects their children. So we really want them to really think about their priorities. How are they prioritizing making decisions, and what information do they need to support their decision making? And this helps us build in again on the algorithm that helps personalize the safety plan based on their priorities, not our priorities as advocates, but their priorities. How do we target their safety strategies? And for example, most women who have children, you will hear them say, and their largest priority is their children. So we want to then provide in the tailored safety plan specific information targeting safety for children, especially in the age range that they have told us. Next slide. So once that information has been completed, you do not have to, it's not longitudinal. People don't have to complete everything to get a safety plan, but the more of those assessed components they complete, the more tailored the safety plan is to their situation and their priorities. So once then the safety plan comes back, updated with personalized strategies and resources based on their input. So they can click on any of the buttons, for example, and there's a protect yourself. There's 2 strategies in the protect yourself that then they can click on, and that may give them specific information about protecting themselves. For example, in the US, we work with the National Domestic Violence Hotline, and I think other countries could do this as well. And we have now personalized the resources based on the user's decision to enter zip code or county. They don't have to. And then we can really break it down to legal services, health services, advocacy services in their community. And we have a direct link that they can live chat with an advocate through the domestic violence hotline or call directly. Next slide. So we also know that for a lot of users, this is a learning opportunity, and for a lot of advocates who use this with their colleagues, with survivors, there's an opportunity to help talk through some of the myths we have about abuse and learn about healthy relationships. So we do have a component that you can click on around learning more about healthy relationships. Next slide. So we have done a significant amount of research using myPlan in the US, but also colleagues in Canada, New Zealand, Australia, Kenya, and we have colleagues working on this in Kyrgyzstan and Brazil, and other countries have contacted us, and then also we've worked with military partners, campus partners. So a lot of people are interested in this, and there's a lot of reasons to think about using it in your setting, and there's reasons to maybe it's not the right fit. So we do know that when we think of a theory of change, we think that there's a lot that needs to happen actually in our experience before the violence ends. So what we know that myPlan can do is reduce the decisional conflict and increase women's ability to make those safety decisions based on their priorities and their risk of severe and lethal violence. It increases the use and helpfulness of safety strategies. I think that tailoring and personalization of strategies to the women's priorities and needs is very helpful. We've seen in our studies in the US that we can increase the ability to safely end an abusive relationship. One of the areas of research that we have little information is when a woman decides to leave, can she safely end the abusive relationship? And in our study, the women that used the myPlan reported significantly reduced risk of future psychological and sexual violence from a partner. And then we did a study with a national study in the US with 18 to 24-year-olds. And what we saw was a reduction in reproductive coercion and their risk for suicide. And in our country, there's a significant increase in young women attempting and completing suicide, especially among African-American women, young women. Next slide. So I'm going to ask, when we get to the question and answer for my colleagues in Kenya to really respond to this, but because they've taken myPlan, adapted it to the context, piloted with multiple survivors and advocates, integrated into their health system where they have community health volunteers working with survivors, and they have demonstrated promising interventions effects. And now they're doing a large trial. Really what we need to know, I think, we have the evidence that this can be effective, and we do not have evidence of harm. We could talk about that in question and answer, but what we can say is that how do we get it out? How do we get it in people's hands? Next slide. And so I'm just going to end with thanking. I know a lot of people think about how can they incorporate a technology-based intervention into their programming. We'll hear that next from the parenting partners that are doing the important parenting work. But I think there's a lot to think about scaling, customizing, but also your policies around user data storage, and safety. So thank you for the time.
Thank you so much, Dr. Nancy. This was really, really helpful. And like I wrote in the chat box, if colleagues attending today have questions, we'll have time to come back to that during the question and answer. For the interest of time, I will now hand over to our colleagues from the Parenting for Lifelong Health to take us through what they prepare for us. Over to you, Jamie and colleagues.
Thank you very much, Rita. It's a pleasure to be here with the Prevention Collaborative, and I'm just in awe of the work that Professor Glass, Nancy, you've been doing with myPlan, and so much to learn. And during your presentation, I was frantically messaging Lucy, who is my colleague, joining me and with MOA on this presentation about so much that we could learn and from the innovations that you've done. What we're going to share is a little bit about the work that Parenting for Lifelong Health has undertaken in the last 18 months in moving towards a digital strategy for scaling up violence prevention programs, and how we've integrated intimate partner violence prevention and assessment into that. Next slide. So just as a background, Parenting for Lifelong Health is an initiative that was started in 2011, and it was started with collaboration with the UNICEF and the World Health Organization, as well as a number of colleagues from multiple different universities and institutions, with the overall aim to reduce the risk of child maltreatment and improve child well-being by developing, piloting, evaluating, and scaling up parenting interventions that go across the developmental course of a child's life. And we, over the past 11 years, have conducted a number of randomized control trials in low and middle income countries to look at the effectiveness of the in-person versions of these programs. And alongside those evaluations, the programs, namely the ones for teens and young children, were disseminated in multiple countries, sometimes at quite a large scale of up to 70 to 80,000 people in Tanzania in the last 2 years as part of a USAID supported project with the DREAMS initiative and PEPFAR. But really the core principles around Parenting for Lifelong Health were that the programs were evidence-based, that they are open source and freely available, that they're adaptive and locally relevant to families and practitioners, that they're playful and empathetic, and that they are strengthening equitable partnerships between South to South and South to North. Next slide, please. So during the beginning of the COVID-19 pandemic, Lucy and myself co-led with a collaboration of many, many different agencies to respond to the increased risks of violence against children and decreased access to support services due to the COVID-19 pandemic. And this resulted in a proliferation of evidence-informed parenting resources that were derived from the Parenting for Lifelong Health program, as well as other programs such as those from Together for Girls and other partners, to really provide these resources in multiple ways, from tip sheets to webinars for frontline service providers, to jingles on Safaricom in Kenya, to animations in Kyrgyzstan. And with the combined effort of multiple partners, we have been to date able to reach 196 million people through these resources. Next slide. But this really brings us to think about what is really needed now that we're looking at the sustained impacts and ongoing impact of COVID-19, and also some of the barriers to scale up of in-person programs, really thinking about what do people need and what do organizations and communities need when it comes to reducing violence against children and supporting positive, playful parenting. So we've really thinking that communities need effective interventions that are low cost and non-commercial so that they can be taken up by multiple agencies. And we need to think about a wide delivery of services and approaches, integrating remote and in-person delivery, that we can reach entire populations at speed that are customized for those local populations and partners, and that are integrated within other services. Next slide. And this has led Parenting for Lifelong Health to think of this hybrid human digital playful parenting support of programs that are in person. We've been developing and piloting also an online version of the in-person programs that can be delivered via WhatsApp or Viber called Parent Chat. We've also been developing a chatbot, which we'll talk about in more detail, called Parent Text, and also Parent App, which is an offline first app for delivery for parents with adolescents. And these are all being in the process of piloting this year with the support of Lego Foundation, the Human Safety Net, and the Oak Foundation. Next slide. So we're now gonna do a little bit of a deep dive into Parent Text, and I'm gonna hand it over to Moa, who's going to take over from there.
Thanks, Jamie. So to give a bit of an overview of what Parent Text is, it's an interactive text messaging service which delivers playful parenting and violence prevention content to parents and caregivers of children aged 0 to 18 years old. And this includes both scheduled messages as well as on-demand content and weekly assessment. And the modules cover everything from positive parenting and learning through play to behavior management, as well as partner relationships and stress reduction. It also delivers this content via creative means such as comics and videos, and includes home practice assignments and check-in messages. And we're also looking at components on how to increase user engagement through looking at personalization and gender targeting and gamification. And specifically for today's webinar, we're also incorporating intimate partner violence prevention content. Next slide, please. So in terms of the IPV prevention content, this is based on the growing evidence of the various intersections that exist between violence against children and violence against women, as well as the emerging evidence of the impact that parenting interventions can have on IPV. So in addition to using personalization based on gender, we're also incorporating a gender transformative approach using content that's derived from existing evidence-based IPV prevention programs, looking to transform harmful gender roles, norms, and power imbalances. Next slide, please. So what does this look like in practice? So a couple of the interventions that we've drawn upon include the Bandabero, the Real of Fathers, and the Maisha intervention. And you'll see on the left-hand column on the slide here, the different topics and modules that they cover and how we've drawn upon these to then develop the 5 different topics that we cover in terms of IPV prevention and parent text, which include treat each other as equals, become a confident parent and supportive spouse, share family responsibilities, resolve conflict peacefully, and listen and talk to each other. Next slide, please. So an example of this would be, here we have an example of a cartoon that we include in our content, and the sharing family responsibilities message, encouraging participants to think of ways that they can share their workload with their partner in order to make life less stressful. Next slide, please. Back to you, Jamie.
Thanks, Moa. So a part of our main effort is to make sure that these innovations are based in evidence. And so the next 3 to 5 years, we'll be working very closely with colleagues to develop, optimize, and refine, and test and scale up the interventions in different countries in the Global South. Next slide. So what are we looking at is when we're thinking about measuring impact, when we do our trials, we'll have robust baselines and post-test and follow-up assessments. But for the internal delivery of the program, we try to embed the assessments within the user's experience in these brief surveys that happen every week or every other week that look at parenting and financial stress, positive parenting, violence against children, child behavior, and efficacy around prevention of sexual abuse. Now, these are anonymous and optional, so people can continue to engage in the intervention without the chatbot, without having to respond to these. But we've also used them to customize the experience so that the content then shifts depending how people are doing week to week. Next slide. We're also looking at measuring the engagement and really learning about how people are enrolled, how they engage, how they retain within the intervention. So tracking enrollment by geography, parent gender, and age, looking at the amount of frequency and duration of the interactions, the completion rate of the parenting tips and the overall program, how they engage with the different parenting skills when they do the check-ins, how they engage with the surveys, looking at dropout and retention and qualitative feedback from parents. And this is something that we would look at with our in-person programs. So now we're learning, how can we assess these and look at the multiple points of data that you get from interaction within a digital technology and sift through that to really answer critical research questions around engagement. Next slide. To you, Mo.
Thanks, Jamie. So in terms of looking at the assessment of the intimate partner violence outcomes, this is split into 3 different parts. So this includes gender equitable behaviors. So this could ask questions such as, how many times did you share caregiving tasks or carry them out together, as well as attitudes toward gender roles in IPV, asking about whether a participant agrees or disagrees with statements such as making joint decisions with your partner. So this is looking at interrelated outcomes, and we're also looking at intimate partner violence victimization and perpetration directly, including 5 different types of IPV in the past month, as well as including asking about overall IPV experiences in the past year at baseline. Next slide, please. Of course, the safeguarding measures in relation to this is paramount, especially given the digital aspect of this. So one main part of this is that when we're assessing IPV, this is done through a secure external website, so no information is saved on the participant's phone. An additional layer of safety here is that participants are asked whether their partner is participating. And so if a male is completing the survey and they're informed that their partner is participating, they will not be asked the intimate partner violence question in order to make sure that their partner is not put at risk. And then we also have keywords. So for example, if there's certain high-risk keywords that the chatbot detects, then the participants will be asked if they want extra support and be provided with referral links. And these links to local referral contact details are also provided at the end of the survey for every participant as well. Next slide, please.
So I'm going to just briefly talk about the next 3 slides to save on time, Rita. So one of the key elements is learning about what's the effectiveness of these interventions and really testing this theoretical model of theory of change where core components of the intervention engage parents in these critical skills that lead to these parenting outcomes that lead to both adult and child outcomes with the ultimate outcome of reducing violence against children. And this is very critical that we optimize our interventions to really fine tune and to make sure that they're having the effects that we are designing them to have. But the next slide is where we're kind of looking into now in the new innovations in digital technology. So looking into how you can both do effectiveness research and implementation science at the same time with hybrid designs. And here we're looking at optimizing and evaluating the user engagement, especially because we know that with digital technologies, the take up and the retention is really low with the lack of personalization. Next slide. And finally, really thinking about how do we optimize and evaluate programs that are delivered as a system of delivery. So looking at an integrative support system where we're trying to optimize engagement and optimize effectiveness through a combined system of looking at population level, digital and remote delivery to in-person and intensive delivery, and thinking about how we can use smart trials like sequential multiple assignment randomized trials to understand how these programs can be delivered at scale within the system. Next slide. And so our overall vision is quite lofty, but I think that together we can really start to try and tackle this by providing evidence-based, informative, and accessible resources to parents, and we're aiming high for 250 million by 2026. Next slide. Thank you very much for your time, and we look forward to chatting more in the discussion section.
Great, thank you so much, Jamie and Moa, for sharing. And I'm gonna hand over to Ruti, who's going to moderate the rest of the session. Thank you so much.
Hi, everyone, and thank you. Mudo, could you go to the next slide, please? So we already see a lot of questions from all of you in the Q&A or in the chat. We'll come back to that in a little while. We had some questions that we wanted to ask both groups here about this this kind of new modality. I think for a lot of us, again, as Rita said earlier on, this is a new way of doing violence prevention and response work. So thank you, Nancy, Moa, Jamie, hi, Lucy, and I know we have a few other colleagues around here who could join us for the question. So the first question, and this is Nancy, let's start with you and then move on to the Parenting for Lifelong Health folks, is what was your motivation to select this particular delivery modality? So Nancy, for you, the app, for Parenting for Lifelong Health, the variety of things that you end up choosing to move forward with. What are some of the benefits and some of the drawbacks to that particular modality? So Nancy, we'll start with you.
So rationale is I'm a nurse and I was providing clinical care to survivors, and I felt like I spent a lot of time worried that I would never see the survivor again. So I felt like I just gave information, lots of resources, lots of suggestions about safety planning. And maybe it wasn't the exact time for her to take all that in, as she might have been in crisis. It might have been in the emergency department or a home visit. And so I started thinking about how do we tailor resources. And then I looked at what was available in the technology. And when we started this, it was 2003. And the internet was, and I used to carry laptops out to shelters and have women go through this with me to help me develop it. And then, so we developed a safety planning intervention that could be used the best available technology. And as smartphones came out, as apps came out, they got more sophisticated. We were able to adapt and make that intervention better and more tailored, more precise to the user. So it was really to help recognize that not all women access services, but those who access service, it could be a tool for providers to help them walk through safety planning and tailor it to their needs. And so the second part of your question is really the challenges. And, the challenges are, for me, the biggest challenge is maintaining a tech-based intervention and keeping it up to date, keeping it relative, using the best technology. As you know, for example, the OS system is constantly upgrading their system. So we have to have the resources to upgrade too. and innovating, I think, costs money. It's really, once you have the intervention and it's being delivered through technology, how do you make it accessible in the sense too that people can adapt it and customize it to their setting, but it's not so expensive that we can't maintain it. And the other is privacy. And one of the questions was, have we partnered with governments or national ministries to deploy this? I think there's a balance there. Survivors don't necessarily, in a lot of countries we work, don't trust their government. And when you start logging on and you put data in, how is that data going to be used? And I think these are all things we have to really consider. And we have a privacy policy on our site. So these are things we think through with survivors to help us better. I think it is completely possible to do that as one mechanism to disseminate the tool, but I think there has to be multiple others because of the way we perceive government in many settings.
So some kind of technological things that you have to think about, even more so in these types of modalities. Jamie, Moa, Lucy, if you want to share with us. Again, the motivation and then maybe hand it over.
To be honest, I resisted the movement to digital for quite a lot of time until it became clear that our normal way of working with in-person programs was just not reaching the scale that we needed to combat violence against children and women. And so we needed to start thinking of more innovative hybrid ways and digital ways of reaching this. And COVID-19 was just like a punch or a kick in the right direction. And so I think that was really the critical need about overcoming those barriers to scale and finding a more cost-efficient and cost-effective way of delivering programs. Now, that's still the research and the verdict is still out on that, but that is where we're going at University of Oxford with and Parenting for Lifelong Health. And I think one area that's critical is about how to reach parents and caregivers who might not normally engage in in-person programs. And we've seen there are a lot of barriers to take up by male caregivers and fathers unless they're really tailored, like some work that have been done with Real Fathers in Uganda and other places for them. And so thinking about other modalities that might be more receptive to other people or people who cannot access in-person programs. I'll let Lucy jump in for a second. I just wanted to name one really challenging element in this movement to digital is that it's very difficult to model or replicate that parent-leader relationship building and social support that happens in an in-person program. And we've tried to do that by making the chatbot or the app that we're developing as personal as possible, but it's not going to, there's no AI right now, and it's not gonna ever be that similar kind of empathetic response that you get from the in-person client relationship. Anything to add, Lucy or Moa?
Yes, just to add that I think we're going to see some of these are empirical questions, and I was thinking, Nancy, as you were talking, that in some ways we may have some benefits from these digital programs in that you're reducing some of the barriers and some of the taboos of engaging, that stop women and families from getting services in the first place. And the flip side, exactly as Jamie said, is that an app can't do what in clinical, I used to work in intimate partner violence social work, and you can't look someone in the eye and have that personal connection that's sometimes so important. And some of the big research questions are going to be around what are those trade-offs with those, and perhaps the future will be, are there effective ways that we can combine them? Which I think we're only at the very start of trying to understand now. I think one of the big challenges for me is that I feel like, in a way, we might know quite a lot about violence prevention, but we're amateurs in the tech world. And the tech world is one in which there are huge interests, huge expertise, and enormous amounts of money. And that is primarily focused to getting more money and not to the goals which we have. And I think that is going to be a challenge going forward, and one that we haven't you know, we haven't worked out how to be as engaging and entrancing as WhatsApp or Facebook or, you know, Minecraft or whatever it's Minecraft, you know, we don't have that expertise yet. And I think one next stage will be working out how we can tap into that. Nancy, it'd be great to hear your thoughts on that, actually.
Well, I think the important thing for us with myPlan, when we developed myPlan, we always envisioned it as it is not a replacement for the experts of advocates, case managers. We hoped for women who hadn't accessed services that this would be a way that they could link to services and make that call. But we also wanted it to be a tool that providers who we know training providers and keeping people feeling comfortable asking these questions is quite challenging. So that a resource that they could provide at the clinic, let women go through it and be there to support them and provide additional referrals. So we see it as part of a comprehensive component and an integrated tool. Yes, it stands alone for some women who download it and use it. And a lot of women tell us that they like it because it doesn't judge them. But I think that what we've done, and it's a learning curve. So, you know, but we have worked with the same developer since 2003 and really moved along with that person. And he became an expert in gender-based violence and really put safety as paramount. So I think it is building relationships and investing that. We've now moved to, because we have so many more users, we have to have a robust support. And that took a couple years to find the right firm. And so, you know, it is a very deliberative process. And there are folks out there that really support what we're doing and are willing to support. And but you're right, there's a balance between the cost of it and getting good people.
Thank you so much for these reflections. I think it really shows sort of the thoughtfulness that has to go into the development of this. I think sometimes people think about technology as sort of something you could just add on relatively quickly. So I wanted to ask you again, both about the process, a little bit more, you've mentioned this already, a little bit more about the process to develop and test the content and delivery of these interventions, particularly in different settings. What are some of the sort of key things that you learned that you would want to share with others who might want to embark on this? And maybe we'll start with the Parenting for Lifelong Health group, since this is a little newer for you all.
We're definitely still deep into that process, Ruti. We work very closely with research and development partners in every context where we are testing the digital and hybrid strategies. So, for instance, for parent text, we're doing pilot studies in the Philippines with Ateneo de Manila University and UNICEF there. In Malaysia, we're working with the government and the university there. Sri Lanka with government and university. So it's very much a partnership where our partners do a lot of that initial cultural adaptation of the messages and the delivery, coming up with what's the best way of nesting the digital strategies within existing services. But the development is really an iterative process. So we have, just recently, sort of very early stages, for instance, started the user testing of both our app and our chatbot in South Africa and in Malaysia, and that is going to be the part of the development because it will require the refinement of the material and the content through feedback. And then the pilot study will be another time when we do another testing. We're trying to design these tests as rapidly as possible so that we can refine as we are delivering, as we're like building that parachute as we're out of the plane kind of analogy, metaphor. And another element of that is the need to make sure that the program is not just the content that we're developing and adapting for another context, but even the way that it's delivered or the way that people get recruited into it. And so that takes a lot of also fine tuning. What kind of external engagement boosters can you have that are very low cost or no cost? And how do you nest it into something that's already been delivered? And so those are some of the questions that we're still thinking about, and even testing empirically using factorial experiments where you can test multiple strategies to boost engagement at one time, as well as the SMART trials where we're testing how you could do that gradual intensity of services based on those who respond, maybe going on lighter touch, and those who need more support to have more intensive intervention.
Nancy?
So so the one thing that I think is, developing a timeline that's realistic, to really co-design an app. So we were asked earlier, have we developed this for adolescents? We have myPlan Teen coming out. It's in trial right now in the US. We've enrolled 600 youth around the US, and we're following them over time. And this is a healthy relationship app. And it's really about what is consent, what is conflict? How do you manage conflict? What is your style of manage conflict? It's much more videos and engaging. And we work directly with youth and co-designing that. We had an outside firm come in and help us, these experts in co-design, because that's not my training. I learned a lot. And again, I understand that takes resources, and we reach out to a lot of people. Twilio, the internet company, helped fund that for us. So there is some companies that will help fund some of this work. And that then we can talk about recruitment and getting it out. With youth, it's social media, it's influencers in their community, it's Instagram, and we had 600 people enrolled, the most diverse sample we've ever recruited, in less than 6 months, because just the influencers and retaining them in the study. So it's very impressive what the youth can do and how they reach out to each other and support each other to do this. We've also, with college campuses, we've looked at dissemination by, college organizations will put on an event, and then we will look at what are the downloads of myPlan in the 50 mile radius, for example, on those dates and the following dates, just to look how the network, how it's spreading out. And that's very interesting to look at how people, the exchange through the social media primarily is how people are, young people are disseminating it. I'm going to ask my colleagues in Kenya to talk about, they're doing a trial right now on how do you get myPlan out nationally in Kenya. So either Ben or Irene, Dr. Decker, please.
That would be great if you can just unmute yourself, I think, and join us.
Are you there?
Sorry, if you just don't mind raising your hand so I can know who it is, and then I will unmute them.
So Ben, Irene, or Dr. Decker, if you want to raise your hand. Yeah, Ben or Irene, please. If you could raise your hand, then we can unmute you to.
Irene did already.
Oh, fantastic.
Thank you. And in response to the reduction of my plan in Kenya, now I'd like to say that the reception on the myPlan Kenya was very good, and most of the women that we had to interact my plan with them were very positive to it. And I say that it is very cool, but of course there were challenges in the use of text. I could share custody if I'm allowed to. myPlan app initial pilot use with women in Kenya. We had the literacy challenges, and doing that the women here
Irene, I'm sorry to interrupt you. We're having a little bit of trouble hearing you clearly.
Can you hear me now?
That's better.
Okay, I was saying that initial stages when we were initiating myPlan Kenya, here in Kenya, there were challenges that we experienced with the women that we had the trials with. One of the challenges was the literacy issue with the women that were using the myPlan for the first time. They thought that myPlan could not be used by them just on their own. They had to be taken through the myPlan by someone else. So to us, it was on our own initiative to make the women understand the questions in the baseline survey, also take them through the myPlan app itself. At first, or at some point, you could read the questions, explain, and then make them understand before they had to make an option or to be able to proceed to the next step. So again, there was an issue with the accessing the myPlan app after even making them familiarize themselves with the myPlan app and telling them that they could use their own. There was a challenge on how to access the myPlan app, since most of them could not access the smartphones.
Irene, I'm sorry to interrupt you again. We were still having a little bit of trouble hearing. I wonder if you might be able to share a few reflections in the chat. And if I could follow up actually with another question to all of you. I think one of the things that's coming through clearly in your experiences, despite these beautiful visuals that we saw of these really well-developed apps, is the process that it takes, not just to develop the content, but to think through what in an in-person program we might call the implementation aspects, right? The recruitment, making sure everything is going as planned, retention, all of those things. You need to think about those, it sounds like, in this type of format as well, and maybe in new ways that we hadn't thought about before. So I'd like to leave time for lots of questions from the rest of you. So just a last question here around advice on really things that when you're thinking about an in-person program you haven't thought about. So important technical considerations that are important to these virtual modalities. So maybe we'll start with Jamie and move on to Nancy and Michelle. Maybe at the very end we can have you speak a little bit to this as well.
So a couple things, but I'm sure Lucy, who's been leading the app development team, can add more. One is that working with coders takes a different kind of language and understanding. And Nancy, you alluded to this with the developer that you've had the fortune to be working with since 2003. It's like learning about how they work or how the things that they need to do. So a simple question about we would like to see, we have a research question about, we would like to see if we get different engagement levels and effects if we personalize by gender. Now, when we say to the coders, can you do that? They were like, yes, that's fine. Everything's possible. But that took rewriting a whole line of code throughout the entire intervention that then had these splits between man and woman or non-gendered specific. And so like learning about like how to work with the tech world, I think is really important, and remembering that it takes time to do things. And just like as if you were going to have an intervention out in the field that was in person and you had and it was being delivered, and then you wanted to add a new module, you'd have to print out all the intervention manuals, you have to do another training. So that's more cumbersome, but still the kind of translation work between academia, implementation, and tech is really important. Lucy or Moa?
I'd love to hear from Mara. I mean, I think we've really realized that people engage with technology in a different way to how they would engage in an in-person interaction. And a good example of this is that we often assume that we can actually, if we're doing something in person, we can get people for at least an hour, maybe longer, you know, especially if you give lunch, then you can really get people for 2 hours and you can do something. And when we've been doing the user testing across Africa, we've had some really interesting responses. There was one father who said something that really stuck with me. He said, as a father, you know, he said, I have 5 minutes a day spare, and that's when I'm on the toilet, and that's when I use the app. And it just really struck me that we have to be thinking about how people engage in different ways, maybe for different time periods, at different times in their life and in their day. Are people using it on the commute home from work, for example? Now, that, of course, gets even more complicated if you're talking about something like prevention of intimate partner violence, where you've got these added constraints on how people can use them. But I think that it has required a greater shift than we anticipated in our thinking about how to engage people and retain them. And I'm in no way certain that we have got it right yet.
Yeah, I agree, Lucy. That's the empirical question, really, that we're working on right now. How do we retain them, and how do we get them to use it and come back? I think that's one of the things we're really interested in, how to come back and reuse it. I want to address, I think there's a really important question that's come up about, you know, for apps where if we're collecting data and doing studies, for example, how do we manage that data, and how do we keep it safe? And so we have two strategies that we use. So myPlan, for example, in the US is public, it's out there. So what we do if we're going to collect data is that we have a separate site that provides a link to people to, if they agree to be in a study, they will link to and answer questions, and that is completely separate from the app. So no data is collected on the app. That is our privacy commitment. If we're in a trial with, for example, like the teen version, or we have a version for immigrants that is being trialed, we copy the adapted app into a research R&D field where it's not public. And so again, it's not public and people consent to be in that, and the data, it's a very similar process of collecting the data, but keeping it separate from, we link it to their use of the app, but they're managed in separate content systems, data management and content management. So I think those are things to really think about because I think we all worry about privacy, and especially for women that we're working with, this is paramount. And you know, people are very sophisticated technology; they can track. So it's not foolproof. None of this is foolproof. And also you have to remember, you have to have security system. There are hackers that will try to hack into your system. And certainly we are constantly addressing issues of that as well. So there's a lot of things to think about as you're developing your tech intervention.
Thank you so much. I have lots of other questions, but let's also take some questions from our chat box. So I'll start with a few sort of clarification questions. Some of these have been addressed. There's a question from Dina about whether myPlan is available in multiple languages.
Yes, well, certainly Swahili, and you know, it really, I encourage you to talk with Michelle Decker or Ujama. They are the experts. They've done amazing work in that area. In the US, it's Spanish. We have a Persian version coming on board. We are in testing now with an Arabic version and French as well. Again, well, importantly, a new version of myPlan, version 4, we call it, will be introduced in January. And it is a much improved from all the research globally that we've integrated, and much more, we think, interactive. As the technology has gotten better and we've gotten better, we've also made it less wordy because, I think when I first started this, I was afraid not to put something in that then it would be information that we weren't provided, but women have helped us sort of cull that down to really what's necessary and what we can link to. And then, I think that, I forgot where I was going with this, but yeah, it is in multiple languages, and we're happy to talk with people about how that would happen. In the new version, there's going to be a content management system that people can collaborate with us and manage their own content so that we don't have to do that.
Can I ask a follow-up question, Ruti, for Nancy? So we are translating the parent text chatbot into multiple languages in some countries, multiple languages in that one country, like South Africa, where we're trying to do it in 11. And the task of translation is cumbersome enough and costly, but then how have you been managing when you have done these new versions and updated it in the consistency for design and version control for that?
We, from the beginning, recognize that as for this new version that we have, for example, our commitment is to have Spanish, so that from the day one, that process is, continues. And we have people that we bring on board that help us do that from the beginning. I think that's the thing, is we cannot do all languages and get it out to people because it just takes. So we recognize that we need to be able to build in languages, and so we work with people who have that interest. And what we've learned over time is we've learned how much time it takes and how much effort on their end. So we want to be clear in the beginning what they're taking on. And we worked really hard with this next version to make the content management system much easier so that translation and management of your own content is accessible. We do retain the rights to review that because we are using trauma-informed language. We want to make sure that it's consistent. So we work with our partners to make sure that it is something that we all agree on is the right tone, the right language, the right messaging. So it's a long process and a commitment by our partners.
And a quick follow-up question, I think, to both of you is around accessibility from Fauzia. Questions around accessibility for people living with disabilities?
Very, very important to us, and we are working. One of the things we're doing in the new version is different colors, different tones that people can move in, brightness and darkness, and versions that you can change the background, for example, to make it easier to read. We are really working on putting more videos, more so that people can listen, and examples. So in the new version, we've tried to work closely with people who have that expertise. It can always be better. We're always learning. My goal is to do everything audio as well, but I know that doesn't work for everybody. But we do link to services for deaf, for example, et cetera. So we try to provide the links if we can't do that ourselves. It's an app. It's just not that. I always remind people it is one tool that we can really help people, we hope, collate and link to resources that will assist them.
And just to follow up on that, So in Parent Text, we have a whole flow that is for parenting with children living with disabilities. So that if a participant indicates that they have a child living with disabilities, then the flow gets customized to their experience. Like Nancy has said, we also have audio, tried to make audio versions of the messages, and also having every parenting tip comes with a visual comic, like you saw in the presentation, but also with a video that is recorded by either a man or a woman, depending on the gender of the parent, explaining the tips. And that is a quite intensive production element as well in the preparation to getting it ready for deployment. But it's something that we wanted to do to make sure, especially for not only people living with disabilities, but people with low challenges with literacy, and making sure that everything can be done in a way that is useful for them. And we're going to find out whether that is the strategies work, but that's what we've tried to do.
Thank you. Again, we have a lot of questions. I don't know that we'll get to all of them, but here's a question from Claire that I think is really important. She's asking, this was specific to my app, but I think applies to both. What are the success factors that are needed here? Right. So one is, you need context specific localized recommendations for resources, but just more generally, what are the success factors that you're considering, if this is a good match, both to a particular organization or a particular setting? And Nancy, you actually mentioned this a little bit in passing in your presentation, if you want to go ahead.
I think that many of the colleagues that we work with are experts in gender-based violence, reaching populations, working with vulnerable populations. The challenge for many organizations is the tech expertise, and I think that's why we've been spending a lot of time with this version and our text experts in creating a scalable version. And what we mean by that there are some components of myPlan that is out of the box, like the templates, the algorithms, etc. We have a toolkit that people can go on and read about how do you integrate it into what we call here in the US victim services. So that would be in the criminal justice system, for example, here, but also into healthcare or on campuses. So we try to provide language to how to integrate it. So that's part of the toolkit. But then we recognize that if we're working with partners in Kyrgyzstan, for example, they need to be able to tailor. The language is different. The resources are different. So we do have components that are a content management systems that allow for customization. And we work with the partners to do that. And then also, simplifying, because, in Kyrgyzstan, the resources are very different than in the US. And that's where our partners come in to manage that. And then we have the platform that then we provide a license to use the platform at minimal cost. We're not making money out of this. This is just to maintain this. And then when Apple does a big OS operating system update, your app doesn't crash because we have maintained it, and then everybody gets the update and you continue along. That's what we're trying to do, is to build a global collaboration. And in that way, the app can store its data in your country. We're not interested in taking, we know that many countries don't want things stored on servers in the US. We agree. So we want to partner, but we don't want everybody to have to build it all again, because the last 17 years has been hard doing this. And it's not just an app. It's, and I know that Lucy and Jamie and Moy can say, you spend a lot of time just trying to help people understand what you're doing at the tech and how to build this. And we're trying to avoid having to recreate the wheel with every new app.
Thanks. Folks from PLH, if you have anything to jump in, feel free. But we have a question from Yina, and also some really nice comments to all of you about the work that you've been doing. So thank you to all of you, as well as the audience who's referring to this. She's asking about what the process looks like to work with public entities. So, for example, engaging with emergency hotlines, whether police is involved, what does that process look like? And I suspect it's similar for PLLH in terms of services for kids and for parents. So maybe PLLH, if you want to start, and then we'll go back to Nancy.
Yeah, I could. We actually had really wanted our colleague from Philippines, Ateneo de Manila University, Lian Peña Alampai, to join us, because the work that they have been doing with the Philippine national government and UNICEF there is quite exciting and innovative, and has taken quite a long time to manage. And during COVID-19, they created their own Philippine set of resources that mirrored the international. So they had webinars for frontline service providers. They had created a Facebook group. They have parent text and parent chat. Of course, there it's called MAPA text and MAPA chat for Masayang Pamilya, which means happy families. And in parallel, they were working very closely with the Philippine government to learn about how they can integrate these resources within a conditional cash transfer system for low-income families that services about 4 million Filipinos with every month, and they have to take part in these family development services. And so to work in the process of working with that was very challenging, because you work with the national government for a review of the content and approval, but the actual delivery of services on a local government unit. So then it's the coordinating of training multiple local government unit people throughout the country, which was quite difficult and almost impossible. And right before COVID-19, we were going to do a 3-province randomized control trial, the in-person program, to see how it would work in different areas. And then COVID-19 happens, and just like a few weeks ago, they were training 700 people a day to try and nationally scale up the resources as part of their monthly delivery of family development services. And so this really took a lot of kind of understanding I couldn't do this, but our Philippine partners do understand what are the different types of people delivering, how can it be adapted for different modalities, what's the basic education that they need to receive in a training webinar for 700 people, and then how to assess the impact. And so they did 700 people a day for 10 days for 7,000 total government workers. And they're doing a pre-post analysis of what's the impact on even the attitudes and behaviors of the government staff members on delivery and learning about the delivery, not to mention also with the parents themselves. So the process of working with national and then working on the local government unit level is quite difficult and takes a lot of years to learn about how exactly to do that. And academics don't come with that training. So they're learning alongside, and definitely from an international perspective, we can only advise, but it's the people who are in country who lead that effort and really own it. So,
Nancy?
So we partnered with, so just some examples, in Kenya, they integrated into the settlements with community health volunteers, really became the folks who walk through the tool with survivors as they access services. It can be economic empowerment, it can be job vocational training, safe spaces, with case management. That's how we envision it. We've used it in healthcare settings here in the United States with sexual and reproductive health. Planned Parenthood, for example, integrated with providers who can provide a tablet and walk through it, or give women a safe space, a private place to go through it on their own. I think what's been really fun, what I am very interested in, is my colleagues in New Zealand used it with the police. The police would, when they got called to a domestic dispute, they would say to the women, they'd give them a card that had, it's called iSafe there, and iSafe, and women could then download it, or they had a smartphone that they could give them, and they could go through it right there. why the police were there, and the police could then help them connect with services. So I think there's ways to integrate it that we could be really creative. And again, it's a tool. It's a resource. It's not. It doesn't fix everything, but it's something that we know police maybe don't want to get into talking about safety planning, or nurses don't want a safety plan. But this is a way that they want to be helpful. I do know that. And this is a strategy they can use to help and do it in a time efficient and with an evidence-based resource.
Thank you. We have a question from Erin that is specific to Jamie and Moa and the intensity pyramid that you shared, and also specific to kind of our times of COVID. You know, the pyramid might suggest that the most vulnerable may need more intense and in-person support. What does this mean when it's not so feasible to meet in person during the COVID restrictions? What are we potentially losing when we can't support in person?
That's a great question. Well, I mean, we are definitely losing the ability to do that intensive one-on-one or one in a group setting of delivery that a lot of those evidence for effectiveness of parenting interventions is based on. There is emerging evidence of the effectiveness of parenting programs delivered remotely. And we have been testing the Parenting for Lifelong Health for Young Children program via Zoom delivery. And this was because we could not deliver it in person over the last year. So we did a trial where we compared the Zoom-based delivery versus one soft lecture that was also delivered via Zoom in 3 countries in Southeastern Europe. And that would be one way where it is possible to do that video-based delivery, to have a bit more of that intensive system of getting that support for more vulnerable people. Another one that we're testing is the version that is delivered through WhatsApp, which can also have a hybrid. When it's possible, you can do part of it by a video and part of it by messaging, which is also more kind of, there's a human element to that. So there's more responsive and can be followed up with phone calls. But really it's, you know, still, if you can't do those consultations or that higher level of intensive case management support in person, then it has to be done through phones and through other means, and that becomes really difficult during COVID-19. Lucy, you have anything for Moa?
Yeah, I just thought I would add, I think you sort of have this inverted version of the pyramid as well. So while we might not necessarily be able to provide in-person support to the most vulnerable, given the increase in scale and the number of people that we're able to reach with something that's digital, we might be able to reach people who are most vulnerable, who otherwise we might not have been able to get in touch with regardless, just because maybe because of safety and risk reasons, they were scared to reach out and meet someone in person. And possibly, and of course, this is still things we're finding out and we would need more evidence for, but possibly by starting with something that's digital and then taking the next step and reaching out for help and getting contact details to a local agency and getting in-person support when COVID allows, that would allow that extra step. But absolutely, it's definitely two sides of the coin.
Thank you. And I think this starts to address also a question from Clara about thinking about hybrid modalities and the kinds of changes that we might hope to see in terms of, I would say sort of, she's asking about the quality of gendered relations, shared caregiving, balance of power, some of the things that we associate with positive outcomes around IPV. I think this also relates, thank you so much, Irene. I'm sorry we weren't able to hear you, but some of the comments that Irene had mentioned around social norms related to violence and how that's affecting how women are using the interventions. So I guess, yeah, asking you all to reflect a little bit more about what do you think is possible around those larger changes within this, within these either remote or hybrid modalities.
If I may jump in here, I think one of the exciting things that we've been discovering as we've been iteratively working on the parent text and the digital side of these interventions is the personalization aspect. So something that comes up a lot from the parenting field perspective is how do we make sure that fathers feel included, which of course plays a big part in building these gender equitable families and relationships and sharing that caregiving and the workload in the family. And I think having the ability to tailor and changing the language just from asking rather than just saying, oh, how are you doing as a parent, asking how are you doing as a father, or how can you embrace this role as a father more is, and we're still discovering what's the impact of this. So that's part of the pilot studies that we're doing now. But I think that's one of the exciting things with working in this digital modality, to see how can we engage both fathers and mothers at the same time through the same intervention, while just changing these small pieces, we might have quite a big impact.
Yeah, and thanks, Mo. And another element with the hybrid delivery is thinking about those relational aspects that require some aspect of facilitated relationship negotiation. And we haven't done this with between men and women caregiver adults, but we are piloting this as a hybrid delivery for the adolescent program, where the offline and the online aspect is done via WhatsApp to just parents, but the key elements where it's around negotiating risk, communicating around financial difficulties is done in person with parents and adolescents together, so that there is that element of that hybrid delivery where some of it you keep the in-person version. And what we will be doing over the next 3 years is working closely with colleagues in Uganda from the Makerere University's Child and Health Development Center, who've been working on the Parenting for Respectability intervention, to look at how you can do that in a hybrid delivery with men and women and children. So what parts can be done offline, and the way that Moa said, for men, targeted for men, and for women, targeted for women, but what parts do you need to bring them together in an in-person setting? So this is kind of and I think, Clara, you're absolutely spot on in the fact that the future isn't just going to be digital by itself, but in most places, the take-up is going to be in this hybrid delivery. And then now the key critical questions are, how much do you need that's in person, and how much do you need that is online, and what is the right ingredients? And that requires a lot of different kinds of innovative research methodologies.
On that note, we have reached the end of our webinar. I really want to thank our presenters, colleagues that have joined the webinar. Mudo, if you could put up our stay connected slide. We encourage you to stay connected with the collaborative, keep asking questions, and this sounds like an opportunity for, here we go. Check out our new website, which we just launched yesterday, where this webinar will be shared. A recording of this webinar will be shared, and stay connected in other ways. Again, I know we didn't get to all of the questions, but I think a really thoughtful discussion today around the creativity, the thoughtfulness, and the innovation that might be possible moving forward. So thank you, everyone, and we'll see you again soon at one of our next events.